Hello and welcome. We're talking tonight about the big topic of epilepsy. We're also going to share with you some interesting news in the medical world about MINCEP epilepsy care. With me tonight is Robert Gumnit, who is the man who founded MINCEP epilepsy care way back in 1964. He's a returning guest. It's wonderful to have you back.
Wonderful to be here, Mary.
Good to see you. He's been one of the real leaders in our country in the field of epilepsy. He was the president of the American Epilepsy Society, as well as the National Association of Epilepsy Centers. And you taught at the U and still do some teaching there?
Yes, indeed.
In the neurology department. So, wonderful, wonderful expert. He also is a man who has written several books about epilepsy, lots of journal articles, and is a true resource in our state. And joining him is Dr. Thaddeus Walczak, who is the new medical director at MINCEP. You've been at MINCEP since 1997.
That's right.
But this new role just began in January this year, 2013. So congratulations.
Thank you. Thank you. It's very exciting.
You had some interesting work spots before you came here. You were out at Columbia University.
That's right, in New York City.
Mm-hmm. And we hear such good things about Columbia Presbyterian, where you worked also.
Well, he more than worked. He ran the epilepsy program there.
Oh, you ran the epilepsy program there. I did not read that, and so it was a catch then.
We were very
got
fortunate
you in
to attract him.
Yes.
Well, it was great coming to this state. My wife, of course, is from here, so like all good men, I followed, the woman home, and she's from Minnesota, and the girls always come back, and so it was great to come
that's
here.
Great. Well, throughout the interview, I'd like to just ask you to touch on a few myths. There are, did I read correctly, 30 million people in the world that have epilepsy?
Boy, I can't keep track of the whole population, but if you define epilepsy as having more than one seizure on more than one occasion, 1% of the population of the United States and a higher percent in poorer countries will have recurrent seizures. It's a very common problem, but people don't talk about it because the ancient Greeks thought you were blessed by the gods if you had seizures. The Romans thought you were cursed. And so we have all of these old, anything that's unexplained, anything that comes suddenly that you can't control, conjures up all sorts of stuff. But it's a disease like having pneumonia. It starts in the brain cells, and it's very treatable.
And that's the good news, isn't it?
It certainly is.
I mean, it's so misunderstood, though, and part of it, I think, is that the brain is not an organ that we understand as much as we do the heart, as lay people at least, or as other organs. But for some reason, maybe the myth started early. I mean, Parkinson's doesn't have quite such a stigma. Some of the other brain diseases that, MS.
And some places it's honored, and some places it's a stigma. It really depends on the culture, and there are lots of cultures in this world.
Yes.
But here in the United States, I'm happy to say that in the last 25 years, people have come to recognize that epilepsy is a brain disorder. People are treated as having a disease, not being possessed by the devil or something terrible like that. And we can get on with life.
Yeah, and you can live with epilepsy, right?
People certainly do.
There have been some advances in treatment since you were on last, Dr. Gumnit.
Yes, indeed.
And I'd love to hear about some of them, and I'm sure that's one of the things the audience is most
I think Dr.
keen about
Walczak should
learning.
answer those questions.
Well, tell us the ones that you're most excited about right now,
Well,
Dr.
there's
Walczak.
been quite a few new medications. So there's now 20 different medications that are available for the treatment of epilepsy. And that's a wonderful advantage because we can now tailor the medication for the patient's specific epilepsy problem. But that means that you've got to diagnose the epilepsy correctly from the very beginning.
So step back and get a
Absolutely.
proper diagnosis.
Absolutely. That is the first step. In the old days when there were 3 or 4 medicines, well, you tried medicine 1 and you tried medicine 2 and you tried 3 and 4 and that was it. Now you've got so many options that you really have to step back, make sure you have the diagnosis down correctly, and then you can really eliminate a lot of the trial and error that used to dominate the field, get the right medication quickly once you make the right diagnosis, get the patient better, quicker.
One of the things that I think about when I think of getting a proper diagnosis is getting fairly early to a specialist, because, I mean, why not go to someone who works with the disease, the condition, the syndrome all the time? But I bet a lot of folks, especially outstate, in some of the more rural states, don't have that easy option, do they?
Well, we could touch on that later, Mary, but I'm very excited about some new treatments that haven't quite yet been approved by the Food and Drug Administration, and that
are pending, as we say.
Right, and our new linkage with the University of Minnesota is going to make us in a very strong position to provide them. Ted, why don't you talk a little bit about that?
One of the exciting things that has happened in the last year is that MINCEP has merged with University of Minnesota physicians and with the University of Minnesota. This has put us in the position to capitalize on some of the recent advances in neurostimulation for the treatment of epilepsy. We've used stimulation of the vagus nerve, the so-called vagus nerve stimulator, for a while, and have quite an experience with that and have done some studies in that. But people are now beginning to study stimulation of deeper parts of the brain or the surface of the brain for the treatment of epilepsy. University has been doing some work in that for years, and so this is an opportunity to have synergy to kind of mix our experience with theirs and take it to the next step.
So MINCEP has become a subsidiary clinic, kind of, or what is the proper?
It's become a program within the Department of Neurology, and we are treating our patients at University Hospital, as well as Gillette Children's and Amplatz Children's. So it's a whole new era for us, and we're very excited about it.
It's a very big decision on your part, wasn't it, to do this?
It's the best place for the future.
Well, that's exciting to hear about. So you also bring in more specialists, more neurologists to be part of the whole show.
Right.
Talking a little bit about brain stimulation, not all patients with epilepsy benefit, obviously. How do you, in a nutshell, kind of define who does benefit most, or what kinds of epilepsy conditions?
Well, first again, you need to get the diagnosis down right. See whether it's a partial seizure or a generalized seizure. And then the first step, almost always, is going to be a proper medication treatment, several trials of anticonvulsant medication treatment. It's very important to address some of the social issues and the emotional issues that pop up, because those certainly affect the epilepsy and affect the tendency even to have seizures. And Bob, I'm sure we'll talk about that in a little bit at some length. But if several medications that are the properly chosen medications, again, that's the key. The key is you've got to get the diagnosis right so that you prescribe the correct medicines. If several of the medicines that are appropriate don't work, then you start thinking about the next step.
How long do you have to, on average, try a medicine before you know it does or doesn't work? I think of antidepressants. You have to at least be on them 3 weeks, correct? That's a long time when you're anxious to get going. Is that also the case with most of the meds for epilepsy?
Well, it depends on how frequently the seizures are happening. So you need to give the medication a fair trial. Generally, within 1 to 2 years, you will know whether whether medications control the seizures or not. And one of the mistakes that is made fairly commonly is that physicians try medicine after medicine after medicine after medicine. You know, there's 20 medicines out there, so you can do that forever.
It could be a long time.
Absolutely, and it gets people very frustrated, rightfully so. So we have learned, and this is really now state of the art, that after 2 or 3 trials of appropriate medications, which, as I said, usually will take 1 to 2 years, if the seizures are not controlled, then you have to reassess. And you reassess in several ways. First of all, you have to make sure that you're dealing with epilepsy. Many of the things that look like seizures superficially really are not. And there are now fairly standard ways of sorting that through by doing what we call video EEG monitoring. We have specially constructed units at the university and in our clinic where you can record electrical activity.
The brainwaves, right?
The brainwaves, absolutely, with video and with other parameters for hours to days. Even take people off medications to actually record the spells and see what it is that you're dealing with.
And often try and stimulate a seizure, right?
You can try to bring on seizures with various procedures, and the goal is to record the seizure, see whether it is an epileptic seizure or whether it's something else that sort of looks like an epileptic seizure, for example.
And find out exactly where it's coming from in the brain, right?
Precisely, where it's coming from and what kind of a epilepsy, what kind of a seizure it is. That is extremely helpful because it tells you that this is in fact a seizure that you're dealing with, an epileptic seizure as opposed to something else. And it can begin to guide you as to whether something a little more aggressive like epilepsy surgery may be helpful. Standard epilepsy surgery tries to make sure, well, for standard epilepsy surgery, you need to make sure that the seizures come from one part of the brain and to make sure that it's
and from not more than one, correct?
Exactly. Yeah, you really cannot take out more than one part of the brain in most cases.
Right.
So you really want to make sure that the seizures come from a fairly defined circumscribed area of the brain. And then you also have to make sure that it's possible to take that part of the brain out safely. That it's not something you need to talk, to walk, to be human.
Is it the case that when you do surgery, it usually is surgery on a place in the brain that is sort of common to surgery as an intervention? I mean, are there certain areas in the brain that are most likely to cause seizures that can be then treatable via surgery?
There are certain parts of the brain where seizures tend to come from a lot more often than other parts.
And that can be good candidates, so to speak,
exactly.
for
That can
surgery.
be removed fairly easily. The brain's an amazing thing. There's so much overlap of function.
We use just such a small percentage, don't we? I mean, that's...
This is where special expertise and experience comes in. Because if you don't know what you're looking for and you don't know how to look for it, you waste a lot of time and miss the opportunities.
And I think everyone watching would agree that we don't want to
no, you don't want to mess
a miscall on our brains. No. So brain stimulation is one of the new or one of the advancing good things on the horizon.
Indeed.
But and I'm going to interject again, there are a lot of people who could benefit from surgery, standard conventional epilepsy surgery, who aren't getting it. They're not being referred to epilepsy centers, or they have some unrealistic fear of what might happen to them. And if there's any message that I would like to get out, it's that if your seizures are not controlled, go to an expert and see what your options are.
That's very interesting because I think probably the average person, and even a person with epilepsy, would think of that as a very extreme, solution or possible treatment.
Mary, what we like to do is do it right the first time. And in this day and age of huge annual deductibles, if you spend an enormous amount of money and it's not spent with the right people doing the right thing, next year you're going to have to spend it all over again if you're lucky enough to get to the right people.
How do you, and this is a big question, but how do you best, as someone watching this show in North Dakota or northern Wisconsin, I mean, how do you decide where to go? I mean, obviously, MINCEP is a great resource, but how do you talk about it in your family and figure that out? I mean, not all doctors are going to be eager to refer.
Well, the fact is, if you're in the Dakotas, if you're in Minnesota, if you're in western Wisconsin, there's MINCEP, and there's always Mayo. And Mayo is a wonderful place, but they don't provide long-term chronic disease management the way MINCEP does. And they'll be the first to tell you. So they're a great place to go and then go home again if everything works out. But if you've got a difficult, long-term chronic problem, I'm a hometown booster. I think you ought to go to MINCEP.
Well, that makes sense to me, too. I mean, the long-term part of being a patient with epilepsy, I mean, it's ongoing. You don't cure it, really, do you? I mean, you control it.
You have to have the seizures controlled. But more importantly, do you own your epilepsy, or does epilepsy own you? You need to find a way to work with your doctor so that you have as much control over the situation as you can and feel in charge of your life. And if you go someplace where they don't know how to help you do that, then epilepsy is going to own you. And that's no way to go through life.
And then it doesn't just own you, but it probably owns your spouse, your children. I mean, there's the whole family that's very much affected, right?
Right.
Do you see some characteristics, just personality-wise, of people who deal best with a chronic illness like epilepsy or condition? Are there certain...
I don't think it depends. I think anybody who faces disease either has a sense of self-confidence and trust in their doctors and they're going to get through it, or they're very anxious and insecure and not sure they're going to get through it.
So
now those people, the first type will make do somehow. Most of us really belong to the second type, and they need to find doctors who understand that and who will support them on this long journey. And I don't care whether it's a chronic disease like epilepsy or a bad broken arm, you've got to go to a doctor who thinks about the issues you're going to face, teaches you how to face them, and is there to support you.
And that really puts some responsibility, too, on the patient to ask questions, to come prepared, to make lists for your doctor.
Amen.
Indeed.
I mean, it's a partnership, isn't it?
It is, and we do spend a lot of time with our patients talking about precisely that. Almost all people that come to our clinic at the beginning spend some time with our nurses through an education session in which they learn not only about the disease, but learn about what appropriate expectations of the patient and the doctor are. So the patient should have specific expectations of their physician, but it also goes the other way around. A physician should expect the patient to at least try to follow the treatment or to say why they can't or they want to.
Right?
Adherence.
Adherence,
Adherence.
exactly.
You don't take orders from your doctor. You adhere to a plan that the two of you agree to. And if somebody's barking orders at you, it may not be the best doctor for you.
That's true. You may have some inner rebellion going on.
You betcha.
But if it doesn't work, if it's not working for you, it's really the patient's obligation to say, hey, this isn't working, And there's so many other options out there now that you can generally come up with something that will work, that will make it work. But you've got to know what all the options are, and you've got to be able to focus them to the patient's particular situation.
I'm guessing as physicians, it's wonderful to have 20 drugs that you can go to now, but it's also putting you in a position of having to be very, selective, and it's a lot more work in a way, isn't it? When
no doctor can understand all of the drugs for all of modern medicine. No neurologist can understand all the drugs for epilepsy and movement disorders and MS and brain tumors. We're becoming very subspecialized. So someone with epilepsy, even if they've gone to a neurologist, probably is going to a doctor who's comfortable with 2 or 3 or 4 medicines. There are a lot of patients who respond to an average dose of an ordinary medicine and they do just fine. But if after 3 months they're not doing that well, I'd get to an epilepsy center.
That's a good, important thing to take away from this show. Don't wait too long. 3 or 4 months, that's very good advice. And the side effects from some of the newer meds, are they less problematical than some of the earlier meds, or do we just have more choices?
Well, they're different. The newer medicines in general interfere with other medications less often, so there's less medication interactions, which is a big thing because a lot of people, especially some of our older folks,
people, yeah.
they take a lot of different medicines.
Right.
So you really have to be on top of that. All medications have kind of their own side effects. In general, the newer ones probably have a little bit less than some of the older ones, but the older ones still have a lot of utility. And one of the interesting things that we're running across is that folks that come out of training programs really forget how to use, the old workhorses.
If they ever learned them.
Yeah, exactly. And
What did you say?
if they ever learned how to use the old reliables.
They jumped in after the
Right.
the old ones were not as used. Well, that's interesting. I want to talk a little bit. We don't have much time left, but about navigating the insurance system, because for someone with a long-term condition, that becomes very important. Do you have any tips in terms of?
Look, first of all, if you already have a chronic disease, then under the new Affordable Health Care Act, the Obamacare, they have to sell you health insurance. That's a wonderful blessing. But watch out for the fine print, particularly for two things. One is the size of the deductible, and the other is whether you can go out of network and see a specialist somewhere else under your insurance policy. That tends
You
those
want to
policies
have that
you want to
option.
have that, and those
Yes.
policies tend to be a little more expensive. I hate to say this, but if you have any kind of a chronic disease, not just epilepsy, be prepared to spend your deductible every year.
Don't be shocked.
The actuaries have figured it out very carefully. Don't go for the cheapest premium. It may end up costing you a lot more. And here again, you've got to take a look at it from the standpoint of where you are. If you're not well controlled, you're just starting down the path, you're going to spend a lot of money, spend it right away with the most expert group you can get to. Otherwise, you're going to have to repeat the spending.
So you're saying don't get a high deductible, especially in the early years when you might be having a lot of care.
Right, and be careful about being able to go out of network.
Okay.
Now, if you've had epilepsy for 40 years, you're stable, you're on one medicine, everything is going well, then you can begin to look at it differently. But most people are going to have to spend a lot of money, and they should spend it wisely.
And thinking of a lot of older people who do get diagnosed, this donut hole issue, I mean, are most people who have epilepsy needing to go, beyond what?
Some people get along do very well on the older medicines in a generic form and don't have a major problem. Some people need the more modern medicines. Some of them are not generic yet. They are expensive, and they are a problem. And you have to learn to discuss it very openly with your doctor and make whatever compromises you have to make.
Well, that's another good point. I think a lot of times people that I talk to in everyday life don't think about talking with their doctor about their insurance somehow. But you should really.
Well, I don't know that the doctors know enough about the insurance policy, but they should be able to guide you as to what kind of care you're likely to need.
If you're going to need a lot this year or the next few years. I want to pause for a minute. We have just a couple minutes left, but we want to put on the MINCEP website. So if you are someone who knows someone who has epilepsy or who's worried that they might, if you want to learn more about MINCEP, you can go to www.mincep.com. And it's a great website, so people
A lot of educational information.
learn a lot there. There are some dangers on people going on the internet in general and reading and getting more of the myths, than the facts, aren't there? I mean, you see that.
Yeah.
We just have a minute left. Is there anything that either one of you would like to say to someone who is struggling with getting a diagnosis, clarified?
Get a second opinion from the most expert group you can get to. In the upper Midwest, I think MINCEP epilepsy care is as good as it comes. But don't expect your family doctor or even your general neurologist to be able to go beyond the simple, basic treatment.
There is so much that can be done now. Epilepsy, even after the first or second seizure, can seem like a hopeless situation. It's not. There is so much that can be done. The very great majority of people can achieve complete control.
And that is wonderful news for people to hear who maybe are just newly getting diagnosed or fearful about finding out. And there are some, we could talk about this in another show probably, but there are some wonderful statistics about how you can prevent sudden death by getting good treatment. And that's
Absolutely.
one of your areas,
Absolutely.
I know. Well, thank you both very much for coming down and really demystifying this condition and giving us some wonderful, exciting new news, and excited about the treatment. And congratulations on your new role with MINCEP.
Thank you. It's great to be here.
Yeah, thank you.
Thanks,
Great
Mary.
to see you again.
Good to see you again.
And thank you for being with us. We'll be back again next week. Until then, have a good week.